Okay, so I think that's it. With that, I'm going to go ahead and introduce our physicians that are here with us tonight. I will start with Dr. Aymen Buchanan. He earned his bachelor's degrees in biology and philosophy from Emory University in Atlanta. He earned his medical degree from the Medical University of Bahrain and completed a residency in internal medicine and a fellowship in gastroenterology both at Henry Ford Hospital in Detroit, Michigan. Dr. Buchanan is a gastroenterologist with us at Archbold Gastroenterology Group here in Thomasville. Dr. Katie Hanisee earned her bachelor's degree from Centenary College in Shreveport, Louisiana. She went on to earn her medical degree from Louisiana State University in Shreveport and completed a residency in general surgery also at Louisiana State University, but in New Orleans. She completed her fellowship in bariatric and minimally invasive surgery at the University of Maryland. She is a general and bariatric surgeon with South Georgia Surgical Associates here in Thomasville. Radiation oncologist Steve Johnson received his medical degree from the Medical College of Georgia. Following medical school, he completed an internship and residency in radiation oncology at the University of Washington in Seattle. Dr. Johnson is board certified in radiology by the American Board of Radiology and has served as medical director of our radiation oncology department at the Singletary Oncology Center since it opened in 1988. Dr. Farquhar earned a bachelor's degree from Williams College in Williamstown, Massachusetts, and a medical degree from Jefferson Medical College in Philadelphia. He completed an internship and residency in internal medicine at Mercy Hospital in Pittsburgh and a fellowship in gastroenterology at, you may have to tell me, Lacknall Hospital in Philadelphia. Dr. Farquhar is a gastroenterologist with Archbold Gastroenterology Group in Thomasville. Dr. Farquhar is actually going to open our program tonight with a short presentation before we take your questions. So please help me welcome Dr. Farquhar.
Thank you. It's good to see everybody eating a high-fiber supper tonight. That should do well for you. And I apologize, I didn't look at the questions on the questionnaire, so I can't really teach to the test. So you guys will be testing me to see how well I cover this material. So this month is Colorectal Cancer Awareness Month, and that gave us a reason to present this material. It's very important from a public health standpoint, but also we're happy to teach whenever we can. And we'll get on with the didactic part of this. First of all, what is colorectal cancer? Obviously, cancer that occurs in the colon or the rectum. And you might ask, well, where's that? And so we have up here the only anatomy picture that we're going to have that shows this large intestine, which is about 4.5 feet long. It starts near your right hip bone, goes up toward your right ribs on the right side, then across the top, and then down the left side, curving around down here toward the rectum. Notice that the umbilicus, the belly button, is right in the middle here. So half of your colon is actually above the level of your belly button. To keep colon cancer in context, I just want to review common causes of death in the United States. And you can see that number one is heart disease, significantly out in front of cancer and way out in front of stroke and accidents. However, if you break this down a little further and just look at causes of death in the United States between ages 40 and 80, 40 and 79, that cancer is actually the number one cause of death. So probably everyone in this room fits into this category, and we need to focus on cancer and how to decrease our risks. Breaking down the types of cancer that we deal with in both men and women, you can see that lung cancer is number one. In men, prostate is number two. Colorectal cancer, tonight's subject, is number three. In women, it's, as I mentioned, lung number one. Breast is number two. and colorectal cancer is number 3. If you add together the two sexes, however, colorectal cancer comes out in front of prostate and breast. So lung cancer would still be number 1, but colorectal cancer is number 2. It's responsible for some 50,000 deaths a year in this country. So your lifetime chance of getting any kind of cancer other than skin cancer is about 40% for both the men and women. And your lifetime chance of getting colorectal cancer is slightly higher in men, about 1 in 22. So this is the overall risk that we have to keep in mind. Among blacks, the risk is a little higher, perhaps 25% higher than in Caucasians. In addition, colon cancer seems to start at a somewhat younger age in blacks. And so, as we will see, we recommend beginning screening at a somewhat younger age, probably age 45 rather than age 50. We're going to talk about this in more detail. So who can get it? As we just discussed, men and women both get it. Really anyone over the age, at almost any age can get colon cancer. About 90% of the time, the people are over age 50. So that's why we start looking at age 50 when we talk about screening colonoscopies for average risk people. Colon cancer can run in the family, and by family we mean mother, father, brother, sister, or child. We're not talking about cousins and great aunts and great uncles or grandparents. It's that immediate family circle that seems to have the greatest risk. Other factors that increase the risk of colorectal cancer, if you've personally have had a polyp in the past, or perhaps even a colon cancer, then your risk is going to be higher. If you have certain diseases of the bowel, that can also increase the risk of getting colon cancers. If there are certain, and these are relatively rare, family genetic conditions that are associated with colon cancer. And then we'll get down to lifestyle, because you can see that sedentary lifestyle, not eating your fruits and vegetables, eating a lot of saturated fats and probably red meats, and alcohol and tobacco increase risk. All these things increase your risk of getting colorectal cancer. However, if you live the perfect lifestyle and you get your exercise, eat your fruits and veggies, etc., you still have average risk for getting colorectal cancer. So you're going to need, or you should strongly consider get screening tests. What are the signs of colon cancer? The first thing on the list here is probably the most important. Often you have no symptoms until things are fairly far advanced, and we do not like advanced disease. If it's a relatively early disease, it can usually be, the problem can often be solved by the medical gastroenterologists like Dr. Buchanan and myself. If it gets too advanced, then we're going to need Dr. Hanisee or Dr. Johnson to help address the situation. But if the patient sees blood in the stool, has abdominal pain that doesn't seem to want to go away, has recurrent loose stools when he didn't previously have a pattern of loose stools, or the other way around, progressive constipation where that was not previously a problem, or significant weight loss, perhaps over 10 pounds, these would be signs that something's wrong, and that person definitely should be checked fairly quickly. If you wait for symptoms to develop, you may already have advanced disease. The good news here is that colon cancer, in the vast majority of cases, gives us some advanced warning. Most colon cancers, not all, but most, can be prevented if polyps are removed years before the cancer starts. We know that since we started aggressive screening for colon polyps, if you look between the years of 1975 and 2000, the death rate from colon cancer actually decreased by about a quarter. We think about half these cases were cases where polyps were removed during colonoscopy, and the other half of that percentage is other reasons, but at least half of the improvement is attributed to the removal of colon polyps. So what's a polyp? A polyp is an abnormal growth on the inside surface of the colon. Remember the picture that we showed before of the colon. Colon polyps only occur on the inside surface. Most polyps start small and grow slowly. As with other general patterns in medicine, that's not always the case, but the vast majority of cases that's true. In general, the larger the polyp, the greater the risk that the polyp would bleed and therefore draw attention to itself, and the larger the risk of cancer. What I'm saying here is that the polyp actually gets the cancer to start with, and we want to remove that polyp before the cancer spreads through the polyp and into the wall or the muscle layer of the colon. If not removed, some polyps can become cancerous, not all of them, but nobody wants to wait around to see if your polyp is going to be a good one or a bad one. We just remove them when we see them. So here's again the picture of the colon. You can get polyps anywhere along this route, from the very end of the cecum, which is where the appendix attaches, to literally touching the anus on the inside. And it's the inside surface where these polyps grow. Now this cartoon sort of demonstrates that they come in different shapes and sizes. The polyp on the right is attached by a stalk. And we like this kind of a polyp because the stalk is actually not part of the polyp. The bad stuff is up here in the head. If we cut through the stalk, the polyp falls free, and this will heal up with no material left behind. The polyp on the other side, unfortunately, is a little tougher for us. We almost have to shave this thing off. This picture shows that the lining in this cartoon, it's kind of the pink layer here, is where the colon polyp attaches. So if we can remove the pink layer, but we can't remove the muscle layer. If we get down into the muscle, we're likely to create a hole and cause a bigger problem. But we've gotten very good at removing even the flat polyps. I'm going to show you some actual images. On the right, we see that very similar to the cartoon, a polyp with a stalk. In this picture, a lasso or a snare has been put around the stalk of the polyp, and this doctor is about to cut through that stalk, just like we showed in the previous diagram. And the polyp on the left, on the other hand, has no stalk. As you can see, it's growing flat against the surface, and this is the kind that we have to get underneath and shave off, cleanly. Now these are unfortunately larger polyps. These take a lot more doing for us to get them off, and sometimes we can't remove the entire, that is 100% of the polyp, in one sitting. So a patient with a polyp this size, we would remove part of it, and we would anxiously wait to see if there's any cancer. If there's no cancer in the pieces that we removed, we have to make a decision. We're either going to go back and remove the rest of it later, or if it really looks too big to get the whole thing out, we might send this patient to Dr. Hanisee or one of her associates. This is one of the special techniques that I was talking about before. This is a large polyp on a stalk. This doctor is about to inject some blue dye along with some gel into the stalk of this polyp, and you can see between A and B that the stalk suddenly gets a lot bigger and it turns blue. That's the dye going in. And then in C, the snare, like we saw on the previous picture, is in place, and then this stalk is transected, and you can see it leaves behind a nice white, roundish, burned area. The polyp head, which is all the trouble-making capacity, is gone, and the stalk has started to shrivel up, and this will heal over completely in a couple of weeks. Now, those were the easy ones because you can see them. This is one of the trickier ones that we have to contend with regularly. If you look very carefully at the diagram on the picture on the left, there's actually a flat polyp here. The color blends in very nicely. It's camouflaged against the rest of the mucosa. Very difficult to see. You have to get the lighting right, and importantly, the patient's colon preparation has to be very thorough so that we have a chance of finding a flat polyp like this. And then we use techniques, once again, to get beneath the surface of this and shave it off the mucosa of the colon, and then we're left with an open patch like we see on the right-hand diagram. So colon screening is what is recommended to find the colon. There are different techniques to try to identify the patients that need to have further work done. There's a multi-society task force that issued recommendations late in 2017. The top two things on the list here are their primary recommendations, that is looking with a colonoscope about once every decade. We'll show you some more pictures of that later. The second test is simply testing to see if there's blood in the stool. That's a test that's also done, that is done every year, not once every 10 years, it's done every year. And if blood is found, further investigation needs to be performed because this test obviously doesn't remove anything, it just looks for blood. The third test up here is this newer test that you see advertised on television, the Cologuard test, where the material in the stool includes material that has been shed or brushed off the top surface of a polyp or a colon cancer. And when they do certain some amplification techniques, they can look for this abnormal DNA. And if a person has it, then they send the patient generally back for a colonoscopy to see where it came from. So similar to the occult blood test, if they find it, they don't know where it came from, they can't fix it, but they know that the patient needs further testing done. I'm not going to spend too much time on the last three tests. Flexible sigmoidoscopy has been around for a long time, and it's very similar to colonoscopy, but it's shorter. And so instead of examining the entire colon, it only examines the lower third. And these last two tests are not available here in Thomasville, and these are third-tier tests according to the multi-society task force, and we generally are going to want to stick with the first or possibly second-tier tests, but we're going to avoid the third-tier tests. So comedians and comics have gotten a lot of mileage out of colonoscopy over the years, and they usually exaggerate things. I assure you that none of our nurses have that kind of an appearance on them. They're all kind and caring people. This is a picture of a real colonoscope curled up on a table here. The business end is down here that gets inserted into the anus, through the anus into the rectum, and then goes up through the colon. In the middle are control knobs that are held by the doctor so he can steer the tip of the scope up, down, left, or right. And this is the end that plugs into the electronic machinery that projects an image for the doctor and nurses to watch during the performance of the procedure. This is a very good test, as we have talked about, for identifying and removing polyps. There can be problems. Bloating, nausea, and pain down in the lower right-hand corner are probably the most common symptoms. They generally go away once the patient is able to pass sufficient gas after the test. Major problems would be bleeding or perforation being a hole in the colon. These are things that occur almost exclusively during the removal of large polyps. So if you have a large polyp, there's a little bit of added risk to removing it, but the risk is not extreme. Here's a picture of an actual physician holding a colonoscope. The control knobs that I talked about before are in his left hand. The business end of the scope is in his right hand. And this is what it looks like in real time as the image from inside the patient is projected up on a screen in the room. The fecal occult blood test is a test looking for blood. I mentioned this before. It is still considered a first-tier option, but if blood is identified, colonoscopy generally is recommended to see where the blood came from. Keep in mind that not all polyps and cancers bleed, and when they do bleed, they don't always bleed every day. So you can get a false negative test if you're just looking for occult blood and the day that you do the test happens to be a non-bleeding day, you can get the opposite mistake as well, is sometimes this test will read positive when there actually is nothing wrong. We call those false positives. All these tests have certain rates of false positives and false negativity. This is the Cologuard test, the abnormal DNA test that you see advertised on television. Same principle, that if abnormal DNA, the abnormal material is identified, you have to have colonoscopy, usually to see where it came from. One of the problems with this test is the false positivity. It has about 10% false positives. We don't really know what to do with those. Those patients go to colonoscopy, but if we don't see anything to explain it, we can't really explain it to the patient either. So everyone is a little nervous when that happens. And right now there's no recommendation on how to follow that up other than maybe do some other kind of a test next year. But that's something that a few people just have to live with, and it's a little bit of anxiety provoking for doctor and patient alike. Sigmoidoscopy, as I mentioned, looks at the lower third of the colon. I'm not going to spend too much time. It's just like colonoscopy, it's just shorter. So who should be screened? As I mentioned, 90% of colon cancers occur in people over the age of 50. So if you have average risk and you're not showing any of the symptoms, you don't see blood in the stool, don't have constipation, don't have diarrhea, then you're probably average risk. You need to be checked when you turn age 50. If there's an abnormal test, such as stool blood test, obviously that's no longer a screening test, and that becomes what we call diagnostic. We know something's wrong, or we have reason to believe something's wrong with that patient. And we also, to maintain average risk, we also want there to be no immediate family members with colon polyps or colon cancer. Normally we start at age 50, as I mentioned, in blacks, probably age 45. Now, if you have above average risk, which would mean you had previously had a polyp or even colon cancer, someone in your immediate family has had colon cancer or a polyp, we would start younger, and we take the youngest person in your immediate family who has had colon cancer, and we go 10 years younger. So if your brother had colon cancer at age 50, we would recommend that his siblings start at age 40. And if, as I mentioned before, if you have certain diseases that your doctor would know about, you might also have to start sooner and be checked more frequently, perhaps every 5 years. That's the standard recommendation for most above average risk patients. Once you start to get into the unusual diseases and special cases, sometimes we repeat the colonoscopy even more frequently. Depends on the situation. So I'd just like to credit these diagrams and images that I borrowed from the internet. I think they're helped with this educational talk. But that's the end of the didactic session, and we're now open for questions.
At what age does the risk end, or does it end?
So your risk never ends. The older we get, unfortunately, we're at higher risk of developing colon cancer. But from the time that a polyp forms until it becomes cancerous can take up to 10 to 15 years. So at a certain point, and a lot of our guidelines say at approximately the age of 75, we would have to sit down with the patient and decide, is this patient going to be around in about 15 years or so? And if so, we can sit down with them, talk to them about the risks, benefits of proceeding with a colonoscopy. If it was a patient, for example, who was 80 years old with a lot of medical issues, and really proceeding with a colonoscopy puts them at higher risk, then that would be a patient where we would say, you know what, we may decide against doing a colonoscopy in that case. And so our guidelines go from the age of 50 up to 75, and above the age of 75, we have to be careful and sit down and discuss with the patient and their family, make sure that we're doing what's in the best interest of their quality of life.
Question is, he has a colonoscopy every 5 years. Is there a chance that he could catch colon cancer within those 5 years, like between the colonoscopies?
So colonoscopies are an excellent test, but they're not 100%. There's unfortunately a very, very, very small possibility that small lesions can be missed. And that's why when patients are above average risk, we say instead of doing your colonoscopy again in 10 years, we want you to come back in 5 years. That's just to make sure that things that may have been missed or things that have grown in between cases are caught early. So the purpose of doing it every 5 years is to minimize the risk of developing colon cancer in between, but unfortunately that can happen at times. And so it is an excellent test, but it is not 100%. And that's something that we have to explain to our patients and make sure we're all on the same page, that there is always a chance things may be missed, things that may grow in between procedures, and the purpose is for a closer look, as opposed to doing it every 10 years, doing it every 5 years, is just to make sure that our patient is safe, and if something starts off early, we can catch it early.
Over the age of 80, does the risk of something going wrong with colonoscopy increase or decrease at the age of 80?
All right, I can. So, in general, colonoscopy is a very, very, very safe procedure. So, like Dr. Farquhar quoted, the risk of something serious happening is about 4 in 10,000. But unfortunately, as we grow older, our colon also gets older. So it can get more predisposed to getting injured. And so in general, yes, an 80-year-old colon is more likely to get injured than a 20-year-old colon, but the risk is still very, very, very small. And that's something that we as gastroenterologists would sit down with patients and discuss prior to proceeding with a colonoscopy. So our goal is to improve a patient's quality of life and not cause harm. And that's why we decide, depending on their medical history, their comorbidities, meaning what other medical problems they have, whether or not that is the safest route to proceed with.
My brother started having to have colonoscomies when he was 45 because they found a polyp. So does that mean I should have a colonoscopy every 5 years now?
Dr. Farquhar, do you want to share the...
Yes. Well, Ed, I'm obviously a quick, unexplained answer, but if he had a precancerous polyp and he's a genetic first-degree relative, and if it's a full brother, then he would be, then yes, then your risk is also considered above average. Not extreme, but above average, and so a 5-year interval would be a reasonable recommendation that many gastroenterologists would give.
And my brother's father had colon cancer years ago. He passed on after years, but...
Okay, again, that's outside the circle of the immediate family. What about your mother? Did not, okay, that's a good thing. But still, you have one first-degree relative with colorectal cancer at a fairly, with a adenomatous colon polyp at a fairly young age. So that sounds like you need one every 5 years.
Do polyps occur at a particular point or area of the colon, and does the colonoscopy test include going up? There's quite a few curves in the colon. Can you go all the way up and cover the entire colon?
Yes, that's our goal with everybody, is to go through the entire colon and actually go usually an inch or two into the small intestine for thoroughness. But as you point out, there are junctures and curves and tight turns in the colon, and it can be difficult to see every square inch of the colon. In fact, I would make the claim that despite our best efforts, we can never see 100%, but we try very hard, especially when going around sharp turns, to look at the inside of the turn as you go, both as you advance the scope in and as you come out again. We have 2 chances at every spot in the colon, and a clean colon is very helpful for doing that.
Years ago, they used to, I think, annually, when you would have your annual physical, they used to give like little packets, I think they called them a smear, that you would do at home and send it off. I've noticed they don't do those anymore. Did they find that that's not helpful, or?
So that is still offered, and actually what Dr. Farquhar mentioned, the options in terms of screening, the second one I believe on that list was the annual fecal blood testing. What a lot of people have shown, and usually a lot of primary care physicians have this discussion with their patients, instead of doing this form of screening every year, a lot of them have decided, you know what, let's do a colonoscopy, and if we find no polyps, we're good for 10 years. And so that is still offered, and if you prefer that route in terms of screening the stool for blood, that is available with the primary care physician. Understanding that if it is positive, then the next step would be to proceed with a colonoscopy. Whereas some people prefer, you know what, let's just proceed with a colonoscopy, hopefully there's no polyps and we're good for 10 years.
With the gentleman that just had the question a while ago about what about in between colonoscopies, would that be a good?
So the answer to that is no. Those are only for patients who are average risk. If this gentleman here had polyps on his first colonoscopy, then he would be considered above average risk. And so in that, when that happens, we actually, those guidelines do not apply, and we decide to go ahead and follow up with colonoscopies instead. And like Dr. Farquhar mentioned, a lot of the stool tests can be false positives, so things like hemorrhoids, things like eating a big steak, things like certain medication, taking Motrin or an aspirin can make that test positive. And so it's just a screening test, but when it is positive, then you go out with a colonoscopy and continue surveillance with a colonoscopy from there on.
Yes. I'm not sure if you have the answer to this or not, but in the future, do you see an easy or pre-op method? It's not very user-friendly.
We've heard this question before. Many times. Yeah, the colon prep is usually the least pleasant part of the whole process. When you come in for colonoscopy, the prep is all done. Some nice anesthesiologist puts you just gently to sleep. You get the test and you wake up and everything's over. But the night before, it's all you. And it's very difficult. It's very difficult to clean out the colon. Colon's a low flow tube, and even if you try to drink the clean out stuff very fast, by the time it runs down through your stomach and 14 feet of small intestine, it's just dribbling. And just like trying to clean a dinner plate with a dribbling faucet, it takes a long time. So you got to drink a lot of that clean out fluid. Sorry. Yeah, someone comes out with an improved version of the clean out every few years, but by and large, they're about the same so far. We'll let you know.
I have a question. I know there may be some people in the audience with inflammatory bowel diseases like Crohn's or ulcerative colitis, because they would tend to come to a talk like this. So could you expound on how frequently you do colonoscopies and what kind of screening you do on ulcerative colitis and Crohn's patients?
So having a diagnosis for ulcerative colitis or Crohn's disease puts you at a higher risk of developing colon cancer. So in Dr. Farquhar's slides, you are not at average risk, and so those are patients that should not be screened with the annual stool testing. Those are patients that need colonoscopy. And when do you get, when are you at increased risk? You're at increased risk if the colon is involved. So ulcerative colitis, by definition, your colon is involved. Crohn's disease, any part of your GI tract, from the tip of your nose till your anus, can be involved. And so you're at higher risk of colon cancer if your colon is involved. And at that point, for example, in a patient with ulcerative colitis, we usually want to do a colonoscopy 8 years after diagnosis, but following that, we do it every 2 years. Every 2 years, we go in, evaluate how active their disease is, take random biopsies. In patients with ulcerative colitis, the pathway in which colon cancer develops is different than the polyp to cancer pathway that Dr. Farquhar spoke about. And so in that case, we actually go in. If we see a polyp, of course, we take it out. But even if we don't see a polyp, we take some random biopsies looking for some precancerous changes. And so it's a little different, but it's important for those patients, of course, to make sure that they get their colonoscopies. And it's determined, developing how extensive their ulcerative colitis is, how much of their colon is involved. But generally, the rule is 8 years after diagnosis and then every 2 years thereafter.
Question. You said a Crohn's disease. Is that in the family of celiac disease?
No, that's different. So celiac disease is when your body is gluten intolerant. So there's a protein in the food we eat called gluten. A lot of times it's in wheat products. And basically your body is unable to handle that. Whereas Crohn's disease is inflammation in your GI tract. So there are different kinds of diseases. And so actually celiac disease does not increase your risk of colon cancer. It can cause other complications of other cancers, but not colon cancer. Whereas Crohn's disease, if it involves your colon, can increase your risk of colon cancer.
Okay, my next question, I saw some questions on there about loose bowels and all of that. But then a lot of times I know cross-contamination, that's kind of hard for you not to get there. And then, like you said, with the gluten-free, it causes, when you eat gluten, it causes you to have a lot of bowel movement. And when you know that you eating the right way, but you still having those bowel movements, a lot of times they're not diarrhea, but they're real mushy.
Correct. So that's important. And what I wanted to clarify from that slide that Dr. Farquhar talked about, it's not a matter of whether or not you had diarrhea or constipation. It's a matter of, for the past 10 years, I've always been regular. I've been going once or twice a day. And then all of a sudden, that started changing. So we have a change in bowel habits. Where I used to be constipated, now I'm having diarrhea, which is not normal for me. Or, I was having a lot of diarrhea and then all of a sudden I started being constipated. It's that change in bowel habits that's more concerning. A lot of the times when a patient develops diarrhea, it lasts a couple of weeks and then it goes away. Or they develop constipation because of a change in their diet or a new medication. But when they were doing a certain thing for so long and then all of a sudden there's a change, then that needs to be investigated. That's the reason you would see your doctor. Your doctor will sit down, review this with you, and decide, there's a change in bowel habits, maybe some other symptoms like weight loss, nausea, change in bowel habits. Let's proceed with a colonoscopy just to make sure. And so there's many reasons someone can get diarrhea, and diarrhea does not always mean, yes, there is cancer. And so that's incorrect. What is, it's more a change in bowel habits, where you used to be one thing, and now all of a sudden you're another thing, and it's been ongoing for months. That needs to be investigated.
Months and years, so like if you, I said I just had this small bowel x-ray done.
Okay.
And it come back negative.
So,
What I'm saying, with me having a lot, never constipated, never.
okay.
Never.
So you're asking your risk of developing colon cancer?
Yes.
But as part of your workup, you must have had a colonoscopy, correct?
Oh, yes.
And
Yes,
so-
I had, four, I believe.
So if they haven't found any polyps, then you're at average risk.
They have found polyps twice out of the four.
Okay. And so polyps in themselves do not cause diarrhea. All right. Diarrhea is being worked up, and they need to find out what's going on. But as part of the workup, they did find those polyps. And so depending on the number of polyps, your doctor or gastroenterologist will say, you know what, we found 1 or 2 polyps, let's bring them back in 3 years or 5 years, depending on that.
But mine's every 3 years.
How do you handle screening when someone has an extreme bend in their colon or intestinal tract that prevents you from completing the colonoscopy?
Well, some colons simply cannot be completely examined by colonoscopy, and if that were the case, you need some alternate imaging technique to look at the upper part of the colon that hasn't been seen. So traditionally, that's been the barium enema used for that. CAT scan could also conceivably be helpful, but a barium enema would be the more traditional approach in someone where you simply can't get beyond a given point because, for example, scar tissue from some previous severe disease, diverticulitis, for example.
It happened to my sister, and he came down and told us about this. Would they have gone down her throat for any reason to try to?
Well, the colon's a long way from the throat.
Yeah,
I mean,
but I thought that the alternative that she came back and I thought that was what they did. It was an unsuccessful.
yeah, you can't reach the colon from the top end of things.
I'm not sure what.
I just wanted to add one thing. Sometimes an endoscopist is unsuccessful in going past that bend. But it's always, and I agree with Dr. Farquhar, there's the barium enemas, and then there are other tests which we don't have available at Archbold, like the CT colonography or a capsule colonoscopy, which are not available right now. But the point I'm trying to make is sometimes on a different day, a different endoscopist, the colon may lay differently. And so if someone's been unsuccessful at one time, maybe a couple of years later, another endoscopist can try and they can actually pass through. So,
Who does this DNA colonoscopy test?
It's a commercially available test that anybody.
TV person.
Oh, you're not TV for, well, it requires that a large stool sample be collected and given to the laboratory that does this particular type of testing. It's a little bit different from the smear of stool testing.
Who does the ordering?
Oh, well, a physician would do the ordering, primary care physician probably most of the time.
The question that I have for you, in the grocery stores, they have like Dannon, Activia, different yogurts that have what they call, I think it's probiotics in it. Is that good to eat that type of food or drink that type of food, even if you don't have any issues, to help with your intestinal flow?
I think you're paying a premium if you do that. There are some people, especially with irritable bowel, who actually feel better when they're on certain types of probiotics or live culture yogurts, which is what you were alluding to. And if it makes your tummy feel better, that's good. But no, I wouldn't do it just on general principles. I would just buy the cheaper yogurt and eat that.
What would you recommend when there is not necessarily strong, but a family history of colon cancer in the females, specifically the preventive measures that you would recommend midwife to be on, and what you would do for early detection, other than the routine detection?
Well, you say it runs in among the females, but is that first degree relative connection there?
Your definition is not first degree. My father's sister both died of colon cancer.
Well, technically, you don't fit into the high category, but still, routine screening is certainly appropriate, and I would, in a case like this, I would lean strongly toward doing colonoscopy rather than the fecal occult blood testing or the Cologuard testing, because I would not sleep well if I were in that situation until I knew that the best test had been done.
Polyps have already been found.
There are a couple types of polyps, but if you're a precancerous type polyp, not cancer, but precancerous type polyps, what we call adenomatous polyps. If any of these polyps were in the potentially precancer family, such as adenoma, then that person is always going to be above average risk, and screening doesn't really apply. Now we're into the higher risk category. Surveillance, we usually call it surveillance colonoscopy, and that would certainly be, depends on how many polyps and how big they were, but it might be done every 3 years, might be done every 5 years, or if it was a very big, scary looking polyp, we might do it in 1 year. It would have to be individualized.
Is there a relationship or correlation between colon cancer and cancers and other organs close to the colon? And can you get cancer on the outside of the colon?
Dr. Hanisee, want to address that, or Dr. Johnson?
So there are several syndromes that have both colon and other types of cancers involved. Their proximity to the colon, anatomy-wise, is not necessarily related. It is possible for cancer of another kind, like for example a gastric cancer, to erode into the colon, but that would be considered direct extension, so not a colon cancer itself. Colon cancer itself originates from inside the colon, though it is possible for other types of cancers to implant themselves on the colon, and then I get to get involved.
Well, one of the reasons is their lifestyle, probably. They have a high-fat diet, eats a lot of red meats, inactivity. All those things lower your risk, so when you do all those things, it increases your risk. I think that's the main. I don't think there's a peripheral estrogen effect, but I think generally lifestyle. You need to be active, get off your butt. Don't eat a lot of red meat, eat a lot of fruits and vegetables. Same for heart disease. Don't smoke. You had a question?
Say that again, Tom.
Doctor's office, sometimes they'll do the stigmatized versus sending you for colonoscopy. Why would they not go ahead and send you for a colonoscopy versus doing?
But for screening purposes, I think a lot of us gastroenterologists have moved away from doing the flexible sigmoidoscopy for screening purposes alone. A lot of times the guidelines say if you do want to do the flexible sigmoidoscopy, you should pair it with an annual fecal test, just because a lot of the polyps do grow in the right side of the colon, so in the first part in the cecum or ascending colon. And so a lot of the times doing just the flexible sigmoidoscopy doesn't go all the way in, and so we can't see the right side of the colon. And so a lot of us gastroenterologists have moved away from doing that. It is still available, it is still in that list that Dr. Farquhar spoke about. But we would prefer doing the colonoscopy, making sure there's nothing, and hopefully say, you know what, come back in 10 years.
Yep. diverticulitis? That's not an increased risk in general.
No increased risk, no. So what diverticulitis is, as we grow older, in the colon can develop these pockets. We call those diverticula or diverticulosis. And when that gets infected, we call it diverticulitis. But it does not increase your risk of colon cancer. But if someone does have a bout of diverticulitis, we want to make sure that they do have a colonoscopy to make sure it's nothing that mimics it. So you want to make sure it wasn't colon cancer that was acting like diverticulitis. But in itself, it will not increase your risk.
You said that don't eat too much red meat. How many times in the morning?
I'll leave that one to you.
Well, I know we do live in South Georgia, and we live in America. I've never really seen somebody put a number on it, but I think a lot of people say red meat once a week, or, you know, one fried chicken leg a week, you know, being reasonable, that kind of thing. I've never seen anybody really quantitate it, but just tons of fruits and vegetables, not heavy and lard, you know, you can eat some green beans down here that are pretty damaging, you know. So these women cook them with fat back in there, and you know, you let them sit around. There's that much fat on top of the pot the next day. So low fat. We ought to start saying low fat fruits and vegetables, and fruits and vegetables without cheese whiz on them. And we know how to make anything fattening down here. So moderation of everything. Moderation in alcohol, moderation in fats. Red meat once a week, 4 ounces probably is reasonable. That doesn't mean a 16-ounce steak once a month.
So I had a question for Dr. Hanisee. So Dr. Hanisee, if I did a screening colonoscopy and there was this big polyp in the first part of the colon, the cecum, and the gastroenterologist did not feel it was able to be taken out endoscopically, and then I refer him to, what would the next steps be?
So if we did see a patient that had a polyp that was unresectable anywhere really, what we would attempt to do is a resection that would be a lesser resection, so we're not taking as much of the colon and not putting you at as much of a risk. And what we do is we can take a biopsy of this specimen. We can either ask our pathologist friends to look at the specimen while we're in the operating room, and if they can tell us that it's cancerous, then we can do a formal cancer resection, which is a little more detailed than just doing, in this case would be an ileocecectomy or taking a small portion of the colon. The other option we always have is just taking the whole resection in order to spare any chances of there being a mistake. A lot of times with these resections, we don't mess with anybody's continence, so we're just taking a certain section and not all of the colon. And so with that, there isn't a whole lot of increased risk if we have to do the whole resection.
How much of the colon can you remove in the first and potentially eliminate?
People live without their entire colon often. We have our patients that have ulcerative colitis, which we've spoken about a little bit tonight. At some point in their life, they do unfortunately get a total colectomy, and we take their rectum as well. They do have a little bit of changes to lifestyle, but we've come a long way where we can actually reconfigure the small intestine a little bit, hook it up to the edge or the anus, and they can have a fairly normal life. Now they do have 5 or 6 bowel movements a day instead of what we would typically have, but they can have a very normal life with this. So I guess that's a long answer for you can have all of it out.
I'm a little bit confused. Is that whole thing in the colon, or is there a large intestine, or how's that?
Yeah, those are synonyms, yes. The whole tube here is the large intestine, also known as the colon.
I guess I thought the colon was smaller.
That's the rectum. The rectum's a small piece at the bottom.
Sigmoid.
When people talk about colon and large intestine, it's the same thing.
It's the same.
Right. And large bowel, they'll call it large bowel sometimes. Large bowel, large colon.
So how much of that can be removed and you're okay?
All of it.
Technically, we can take all of that out, though that does change the lifestyle. But we have patients who have a very high increased chance of having colon cancer. We'll take the whole colon and the rectum and reconfigure the small bowel to the anus, and they can live their lives pretty normally. And take the rectum too. Some patients, depending on what kind of cancer they have, do unfortunately have to have what we call an ostomy or a colostomy. Those are usually patients with very low rectal cancers where we have to take a lot of the anus as well. But for the most part, we've come a long way in keeping that from happening. There's a small percentage of patients that actually have to have that.
Well, I had a cousin that had colon cancer, 13 years of, and he was on, had a bag for like 9 months at a time, and might have had a little longer. And they just reconnected him, a lot of trouble, but he's ready to go now.
Yes, so sometimes when patients have gotten what we call neoadjuvant treatment or treatment before we do our surgical treatment, they can be tough to hook and dangerous to hook patients back up. And so we'll have what's called a temporary ostomy with plans to go back and reverse it. And, every patient's a little bit different, so you kind of have to look at them and what's the best option for them. A lot of times coming out of chemotherapy, they're very weakened immune systems, and having something like a leak from where we hook them back up can be fatal. And so we can be extra cautious and do a temporary ostomy like you're describing.
How many rounds of chemotherapy you had before your body starts rejecting, numerous?
I'll take that. That's the closest. I'm a radiation guy, but I've seen lots of chemo. It just depends on what chemo you're getting, really. Some of it's really, like for the GI malignancies, it's a lot of 5-FU, and that is really, really well tolerated. I've seen some people feel even really good getting that drug. So if you get adriamycin, there is a definitive number of milligrams you can have of adriamycin. Some of the other drugs cause peripheral neuropathies, and that limits how much you can get. Some are toxic to the kidneys, and if your kidneys start dysfunctioning, you have to quit that particular drug. So it's all over the map as far as how much you can tolerate. So there's no limit. And radiation's the same way. A lot of times people think if you got radiated in one place, you can never get radiation again, but you can get treated in another part of your body. And then sometimes we can even re-irradiate in an area we treated before. So it's just so individual. When you get into the cancer part, it's so individual that it could be 10 years later and you can re-irradiate a small area inside a previously irradiated field. So like we were saying earlier, we've come a long way in radiation and chemo and surgery. So it's not nearly as debilitating as the treatments used to be.
Any other questions? Anything that any of the physicians want to add, or?
Just thank everybody for coming. I think we've got to talk a lot about screening today, which is fantastic. I just want to point out that should unfortunately something did come up on one of these screenings, we have an excellent team of oncologists, radiation oncologists, and an awesome group of surgeons. So we have a lot of things to offer here. Should you, hopefully not, but should you need us.
How is the diet, you said no red meat or very little red meat, or the fruits you eat before them, how does that help you? What is it about different foods and vitamins? What are you doing?
Well, one part is just a physical component of eating fruits and vegetables. decreases the transit time of stool in the colon, and that seems to be protective. The other thing is cooking meats at real high temperatures creates some chemicals that can be carcinogenic. And so grilling out a lot, or, just make some chemical changes. So there's some actual chemical things that can happen. Beyond that, and inflammation, there's some inflammation that can occur with certain foods. So I think a combination of all those things. And it's not like eating red meats increases your risk of colon cancer from 0.5% in your life to 30% in your lifetime, but it's enough to pay attention to. And I've also read, just for all the coffee drinkers, there's talk about coffee being protective and statin drugs. So who's not on a statin drug in here? No hands. So coffee may be protective, so I'm gonna stick with that one.
I'll just add a few more lines to what Dr. Johnson said. So there's been studies that show, of course, there's a correlation with diet and exercise and obesity, but the biggest risk factor, I think, are two things. Age is one of them, and genetics. So your family history predisposes you more than what you eat or your lifestyle, and then second is your family history. And so hopefully everyone should get their colonoscopies early or appropriately, catching their things before they become cancerous, or even if they become cancerous, we can catch them at an early stage where surgery alone can be curative, et cetera. Okay? And so I think if you haven't got your screening colonoscopy, or you just have this discussion with your primary care physician, and studies have shown that getting your colonoscopies or screening in any form does improve outcomes, just make you live longer and healthier.
Thank y'all for coming.
Thank you.